Welcome to the Healthy Living series presented by Dartmouth Health. I'm Angelica Ladd, Community Relations Specialist here at Dartmouth Health. And today we're joined by Rohit Reddy, MD, a general neurologist and epileptologist for Dartmouth Health. Dr. Reddy will discuss epilepsy treatment and management. Dr. Reddy is a New Jersey native. He attended medical school at Rutgers, New Jersey Medical School and graduated in 2017. He went on to complete neurology residency and a fellowship in epilepsy at the Albert Einstein College of Medicine, Montefiore Medical Center in the Bronx, New York. Dr. Reddy completed his fellowship training in epilepsy in 2022 and joined Dartmouth Health in September 2022. He currently sees patients in both Concord and Manchester. Dr. Reddy fully embraces all that New Hampshire has to offer, and his hobbies include fixing and riding bikes, hiking, building computers, reading, traveling, and more recently, learning how to ski. Dr. Reddy, where are you learning how to ski right now?
I actually went this past Saturday to Pat's Peak for my first ever ski lesson.
Oh,
and I didn't
awesome.
fall, which is reassuring. So I think I'm off to a good start.
That's awesome. That's actually right in my backyard. So that's very cool. So Dr. Reddy, thank you so much for being here. And I'm looking forward to hearing more about your presentation. So I'll let you take it from here.
Yeah, thank you for having me today. It's really a privilege to be able to give this talk today about not only neurology, but a subspecialty of neurology, epilepsy, which is an area that I'm particularly interested in and passionate about. Just to start, today's talk is going to be about epilepsy, what it is, what to know from the patient perspective, how it's diagnosed, how it's treated, and special considerations in terms of certain patient populations and what to look out for and why it's important to make sure you follow regularly with a neurologist if you have epilepsy or any kind of seizure disorder. Okay, so this is very important. So what is epilepsy? A good way to think about it is just to conceptualize a circuit in your head and think about it getting short-circuited. So essentially what that is sudden bursts of electrical activity from various neurons in your brain. They're not controlled, they're not regulated as they normally are, and there's an excess amount of electrical activity. Oftentimes it can be synchronized or happen all at once, which is why you see involuntary movements. You can see abnormal behaviors, you can see loss of consciousness and awareness. And there's many different kinds of seizure types, and there's different kinds of epilepsy, which I will touch upon in the next couple of slides as well. And an important thing to know is that epilepsy is a neurological disease. So what it essentially is a condition in which people are predisposed to having seizures, and this can be from a wide variety of underlying causes, some of which are genetic, some of which are inherited and run in families, but some which happen as a result of things like traumatic brain injury and strokes and other long-term chronic damage to the brain. Up to 10% of people actually, this is interesting, can have a seizure in their lifetime, but that doesn't mean that they have epilepsy. If you just have one lifetime seizure, that doesn't mean you have epilepsy. That just means you had a seizure. So an important thing to note is that a seizure is a symptom. It's not necessarily a diagnosis. And the prevalence of epilepsy, meaning the amount of people that roughly have it, is about 1.2%. So this is approximately 3.4 million people nationwide. So this diagram, this is actually a diagram that is put out by the ILAE, which is the International League Against Epilepsy. It's actually the global organization of epilepsy experts, and they come up with ways to conceptualize and organize various seizure types, epilepsy syndromes in a way that makes it easy for different providers, different neurologists to understand what we're talking about when we talk about different patients to each other. So there's some kind of standardization in terms of how we describe patients. So the way in which we look at it is, one, the seizure type. So is it a focal seizure? Is it a generalized seizure, or do we not know, or are we not able to distinguish between the various types? And also epilepsy types. So epilepsy being more than one seizure over a period of time? And are they combined? Are they focal? Are they generalized? Or do we not know? And then there are various syndromes, which we have to take into consideration: the seizure types, the patient's history, the epilepsy types, in addition to the etiology, so what the underlying cause is, and then we can give it a unifying diagnosis or a label. And this is super important because it helps us figure out the appropriate course of action, how we work up patients, what medications we put them on, what the prognosis is. And yeah, it's just important for figuring out the course of the disease, because oftentimes, epilepsy for the most part can at times be a lifetime disease. So it's important to be able to give it a right label and be able to treat it appropriately. So another important concept, and I think this is very important not only for patients and caretakers, family, but also for other providers in the medical field to be aware of. So oftentimes, and we also get a lot of these patient referrals as neurologists. There are things that look like seizures, but they aren't. So we call these mimics. So fainting or syncope is the medical term for it. So oftentimes when you lose consciousness, when you fall down, you can have brief twitching in your arms, your neck, your face, and your leg, because of disrupted blood flow to your brain when your blood pressure drops and you pass out. That's not a seizure. That's just a result of decreased blood flow to your brain. So it's not a result of excessive electrical activity in your brain, which is what an epileptic seizure is. There's also what we call psychogenic events. So things like panic attacks, things like anxiety, stress. Oftentimes people can manifest their symptoms through shaking, through decreased awareness, and other things which may look like seizure activity, but in fact aren't. Things like parasomnia. So what parasomnias are sleep disorders. So any kind of abnormal movements in sleep, jerking in sleep, talking in sleep, things of that nature. And migraines. Interestingly enough, migraines and epilepsy actually share a lot of overlapping pathology. So especially migraines which have so-called complex features. So if they have additional features like sensory changes, being unable to move certain parts of your body, weakness, sometimes you can have changes in your level of awareness. It's important to be able to distinguish these from epilepsy and from seizures. And strokes, things like TIAs or transient ischemic attacks, where you can again have alterations in consciousness for a brief period of time. You can have inability to move part of your body, different neurological signs, and it's important to be able to distinguish between them. And a lot of neurologists are experts at being able to do this, because it not only is important for diagnosing a patient, but also treatment, because you don't want to treat people that have some of these conditions with anti-seizure medications, because that's not treating the underlying condition, and it can cause more harm than benefit in these patients. So on the flip side of this is cases where we miss epileptic seizures, or we might give them a different label. So we like to call these conditions chameleons. So there are some rare seizure types that can have weird physical and clinical manifestations, or they can have strange symptoms. Like certain seizure types can have changes in your sense of taste. You can have changes in your sense of smell. And it's important to be able to tease out these little differences to be able to pick up what's going on with the patient. Sometimes other things which can be more likely or more straightforward. So, for example, in a patient with heavy alcohol use, who drinks a lot, they're more predisposed to having alcohol withdrawal symptoms. So in these cases, it's not they do have a seizure, but it's as a result of increased alcohol use and suddenly stopping, and that can provoke a seizure, and that's treated separately. In that case, we have to treat the alcohol withdrawal symptoms instead of the seizure itself, because it's a symptom of the alcohol withdrawal. So now that we talked about epilepsy and being able to distinguish what a seizure is and what the various different types are, how do we diagnose it? So again, all general neurologists are trained in diagnosing it and being able to identify it and treating epilepsy and seizure disorders at a certain level. Some neurologists, such as myself, have pursued additional training. This is typically 1 to 2 years after completion of residency to become more specialized in treating patients with epilepsy, not only in terms of knowing the different medications, but also the various other methods for treating seizures, which include surgical treatment as well, and being able to refer patients to surgical centers in the event that they need that level of care if they're not responding to trials of anti-seizure medications. But just like anything in medicine, and particularly in neurology, being able to diagnose epilepsy is being able to get a good history. So you need to be a good detective. You need to ask a lot of questions. So oftentimes neurology visits can take quite a bit of time, especially if it's a new patient visit, because it all, the devil's in the details. We have to get all the information that we can. We have to ask the right questions. We have to ask patients' family, caretakers, family histories. These are all very important. And this is important because this will determine what kind of testing we order. We don't want to just shotgun our testing approach and order every single test out there, because testing is nuanced, testing is expensive, not only for the patient, but also for the hospital system, et cetera. So we want to be efficient in terms of how we do this, but also be, a good judge of ordering testing when it's appropriate. So again, getting a nice, good detailed history from a reliable source, whether it be the patient themselves or family, close loved ones, it's very, very important. So testing. So now that I talk about diagnosing it, so there's 2 different ways to approach this. It's inpatient versus outpatient testing. And I'm going to touch upon the various different types, and as well as the facilities and the capabilities we have here at Dartmouth, both in the southern New Hampshire region, so near Concord, Nashua, Manchester area, and more in the northern region, so near Lebanon, where the medical center is, where the academic medical center is. So there's different tests. So MRI is probably the cornerstone of the imaging, probably the best imaging test that we as neurologists would like to request on patients who have epilepsy or suspected epilepsy. This gives us a good picture of the brain, allows us to identify any areas which could serve as a cause for seizures, or an underlying cause for epilepsy, or a focus, or basically a seizure focus. This is important for determining treatment in the event that medications don't end up working for that patient. Also, EEG, or electroencephalography. There's 2 ways in which to approach this, both in the inpatient and outpatient setting. So there's something called a routine EEG, which is usually our bread and butter as neurologists in terms of approaching EEGs in the outpatient setting. These typically last anywhere from 20 to 30 minutes in duration. They're done in the outpatient office. So typically you'll have, usually a neurologist will order it. You'll schedule it. You'll go to one of our clinics. Right now it's in Manchester. That's where we have our EEG technicians. You come in, they record you, they put little electrodes on your scalp, kind of like an EKG with the same, stickers, same concept, but we put it on your scalp, and we look at your brain waves. We take it off, and then you go home, and we look at the EEG, and we write a report, and we let you know the results. There's also something called an ambulatory EEG, which is essentially a prolonged EEG. So what you do is you come in, get the electrode attached to your scalp, you go home for a day, for 24 hours typically, and then you come back. You actually go home with a portable machine. So you actually go home with it, you come back, and then they take it off, they upload the data, and we look at it. And this is more valuable in some ways than a routine EEG, because it gives us not only much more data to look at in order to capture events or seizure activity, but also allows us to look at various different states of arousal. So wakefulness, drowsiness, sleep. It allows us to capture all these different states. And this is important because there are some events and some seizure types which tend to happen mostly nocturnally or during sleep and drowsiness. So it's important to be able to catch seizures in those timeframes as well. And then going on to the inpatient setting, there's something called an epilepsy monitoring unit, or an EMU. Most large medical centers that are university affiliated will have one of these. And as far as I know, in New Hampshire, the only one is at the HMC in Lebanon, where the academic medical center is. And this is actually a level 4 epilepsy center. So what that means is that it's got the highest level, the highest rating in terms of epilepsy care and comprehensive management. So it includes anything from EEGs and basic outpatient clinical care all the way up to inpatient hospital stays where they attach an EEG to your head for a couple of days in an elective admission to monitor seizures and plan and map different areas of the brain which are identified as having seizure potential in patients that don't respond to medications or a little bit more complicated because they might be candidates for surgical removal of parts of the brain that are generating seizures, or candidates for things like deep brain stimulation, an RNS device or a VNS device, which are basically neuromodulatory devices that get implanted that send electrical signals to basically terminate seizures before they can spread to other parts of the brain and cause convulsive generalized seizures. And it's also important to make this distinction because EMU hospitals that have this, they also have specialized staff. So not only do they have the neurologist and the epileptologist there, and not only do they have neurosurgeons who are trained in treating and managing patients with epilepsy, but they also have staff, so ancillary staff, nursing staff. They're trained to identify seizures, be able to carefully take care of patients with this. So oftentimes they will have seizures in the EMU because we try to provoke them in order to be able to map them. So we also want to be able to catch them early, not let them go on for too long, and be able to end them safely. So nurses will be able to identify them, notify staff, they'll be able to give medications to terminate the seizures before they get too prolonged. So again, this is it's a comprehensive level of care, which is why it's important to make that distinction. These are all important because they help individualize care to the patient. So oftentimes care has to be made on a patient by patient basis based on their preferences, what their goals of care are, how aggressive they want to be in terms of managing their seizures. And it's important to be able to get this in every single patient that we see. So this is a nice diagram, and I like to show this not only to other providers, medical students, residents, but also just the general public as well, because it gives you a good idea of how much we've come in the last century in terms of being able to treat seizures. So previously, as you can see over here, 1910s, 1930s, 1950s, we really didn't have a whole lot of medications, not a whole lot of drugs to be able to treat epilepsy and stop seizures effectively. And a lot of these early medications, they were effective at what they did, but they often had a lot of side effects, and they had to be adjusted very carefully. And tipping, the dose of a patient over a certain level could result in pretty significant side effects. It was sort of a very delicate balancing game with a lot of these early medications. But as you can see here, from 1950s, 70s onwards, there was a huge explosion in research in various different medications. And in the last 30 years alone, in the last 20 to 30 years, there was almost an exponential increase in the amount of medication that we have available to be able to use in patients. And this is very important because a lot of them have very specific indications, meaning they can be used to treat very specific seizure types. And it gives us a lot more flexibility in being able to treat patients, whereas they may have been, written off earlier as having seizures, not being able to be treated or not responding to medication. So essentially, we have a lot more options these days than we did even 50 years ago. So talking about that, so what if medications don't work? So the main approach to treating epilepsy seizures is to use anti-seizure medications. But what about cases where they don't work, meaning patients continue to have seizures despite being on medication? So our goal as epileptologists, as neurologists, is to be able to achieve seizure freedom. So we don't want patients to have seizures once they start taking medications. But what if they do? What if they just are not able to be controlled, or they just can't tolerate the side effects of medications? So this is what is termed medically refractory epilepsy, or medication-resistant epilepsy. So usually it's like 20 to 30%. The higher end would be 30% of patients in general with epilepsy tend to have this. They tend to have medically refractory epilepsy. So this means that they continue to have seizures despite trials of 2 appropriately chosen anti-seizure medications. So despite being on 2 medications, they still continue to have seizures. Doesn't mean they continue to have them at the same rate. They just continue to have like any kind of seizures. Um, and this is important because based on the type of seizures that they have, the medications that they responded to, they may be candidates for referral for surgical evaluation. This ties into the whole inpatient side of seizure care and monitoring in the EMU. And as I was hinting at before, there's various options nowadays. They can include things like vagus nerve stimulator or responsive neurostimulation or surgical resection, meaning they take out a small part of the brain after an extensive amount of testing, neuropsychological testing, mapping. It takes a whole team to get at this, to formulate this plan. And oftentimes it's a huge conference that involves neurologists, social workers, neuropsychologists. It includes neurosurgeons. Everyone sort of puts their heads together to come up with a unified plan, taking into consideration, what the patient wants too. So it's a back and forth discussion. It takes a lot of planning and coordination. There's also non-pharmacological, non-interventional treatments for epilepsy, and these include things like the ketogenic diet, hormonal regulation, which both have their pros and cons and can be a little bit tricky in their own way. Another important topic in epilepsy is this thing called SUDEP, or sudden unexpected death in epilepsy, which is actually getting a lot more awareness nowadays. And it's something that we try to counsel and inform all our patients with epilepsy on, regardless of how well their seizures are controlled, but typically tends to affect those which don't have well-controlled seizures. So the incidence of this is about 1 in 1,000, and it is essentially what it's named. So it tends to be like a sudden unexplained cause of death. Typically happens during sleep overnight, and it's thought to come from cardiorespiratory arrest. So usually there's some abnormal breathing pattern which happens right before there's abnormal heart rhythm, and then the heart just stops having electrical activity and stops beating. And this is very important because we want to be able to prevent this. Even though it is, generally speaking, relatively rare, it's still pretty significant to warrant discussion with patients and make sure that we control their seizures as well as possible. Another important topic in patients with epilepsy seizures is to talk about driving restrictions. So coming from New York, this is a lot more significant up here than it is in NYC, because over there's a reasonably good public transportation system, including buses, subways, etc. In other states, for the most part, such as New Hampshire, not being able to drive is a pretty big deal. Not only because you need to be able to drive to get to work, you also need it to get food, to get other things. It's essentially mandatory to be able to have access to a car in some way, shape, or form. So an important thing is if you have seizures, if you have epilepsy, and you're not well controlled, or you just had a seizure, it doesn't matter what the cause of it is, you need to be seizure free for a minimum of 12 months, and this interval can be shortened if you're supported by a physician, typically a neurologist, before being able to drive again. And physicians aren't required by law in New Hampshire, and there's a couple of other states in the New England area and in the Mid-Atlantic area where doctors don't have to report this to the DMV. It actually falls onto the patient to report this to the DMV. And the DMV is actually the one that determines whether a patient will get their driving privileges reinstated, if they're going to be able to drive. The physician just informs the patient of this and will fill out any forms or anything else that's requested by the DMV. But the DMV is basically the point person in terms of determining this. And again, this can vary on a state-by-state basis. I was just talking about the restrictions here in New Hampshire, but it's important to look up the restrictions in the state that you're in or are planning to move to or live in. Okay, so another area that's pretty important is how does our management of epilepsy, how is it affected by certain patient populations? So how is it affected, or how is it different in children, in geriatric patients, the elderly, or in women, especially in women of childbearing potential, or pregnant or planning to become pregnant. And I call these special populations because there's different precautions, there's different things you have to be aware of and think about and ask patients prior to treating them and also during treatment. And medication risks, dosing, all of that changes, and you have to think about it very carefully. Okay, so epilepsy in children. So this is typically not something that I would manage as an adult neurologist, but something generally to be aware of in terms of various patient populations. So this is typically managed by a pediatric neurologist, which is a pediatrician who's trained in neurology. So they have additional training in pediatric neurology, or a pediatric epileptologist, which is further training on top of being a pediatric neurologist. So the important thing to note is that metabolic rates in children are usually much, much faster. So they tend to absorb medications and they tend to get rid of medications in their system a lot faster. And they're also constantly growing. They're gaining weight, they're gaining height. And it's important to note that medications in kids is usually dosed based on their weight. So this typically changes at every visit, depending on how far apart the visits are. With pediatricians, it can be any time from 6 months to a year, more than a year. So it's important to get children's weight at each visit and tailor the medication dosing based on that. There's also additional issues to be aware of in epilepsy in a pediatric population. A lot of it can interfere with school and academic performance, especially if they're having events during the daytime. It can affect their concentration, it can affect their ability to learn. Oftentimes, a lot of kids with epilepsy, they will have something called an IEP, or an individualized educational program, that's instituted by their pediatrician or their pediatric neurologist to help them be able to retain and learn while their condition is being treated. Injuries and accidents. So children already, like to run around, they like to go on the playground. They tend to get a lot of bruises and scrapes, but that's in general. But in kids with epilepsy, there's other things to be aware of. So things like sports, like being able to swim, being able, like climbing things. So if they have seizures when they're swimming, or if they're climbing, they have a increased chance of injury because they have no control over their body during that interval, and they can fall, they can injure themselves. So generally, there's an increased risk for injury in these patients. And the important thing, and this is getting a lot more traction more recently, is just like the social stigma. So a lot of people aren't aware of what epilepsy is, and sometimes they just think the patient's just doing this themselves, even though they're not. It's abnormal activity in their brain that they have no control over, and that there has to be an increased awareness, not only by their peers, but also the staff, nursing staff at schools, that need to be able to respond to and be able to treat it appropriately, not just brush it aside. And just chalk it up to the kid just acting weird or having abnormal behaviors. Just being aware of their condition is key. Another population is the elderly, so geriatric patients. So this is the flip side of pediatrics. They tend to have decreased kidney and liver function, so their kidney clearance is a lot less than it would be in a much younger population. So dosing typically has to be less, it has to be decreased. Oftentimes, older patients are on plenty of other medications. They can be on blood thinners, they can be on medications for their heart, they can be on medications for cholesterol, and there's a higher risk and a higher chance, a higher likelihood of having drug-drug interactions. So they can produce toxic levels of certain medications. They can make certain medications like blood thinners work less effectively because they increase the liver metabolism. So it's often important to be able to, again, it's a balancing game. It's being able to understand the interactions between the anti-seizure medications and the other medications that the patient is on, and also being able to change the dose appropriately, and also picking the right medication for that patient so as to reduce the likelihood of this happening. It's also a higher risk for medication side effects in this patient population. So a lot of anti-seizure medications in general have an increased likelihood for causing drowsiness and sleepiness, and this can be much more profound in geriatric populations, especially patients populations that don't have a steady gait or have walking difficulties or use a cane or rolling walker. It can lead to things like increased risk for falls, which tend to be more debilitating in the elderly due to various different reasons, including but not limited to being on things like blood thinners. So it increases, risk for injury. So we also have to take that into consideration. A lot of anti-seizure medications, they also increase bone turnover. They actually cause increased metabolism of bones, actually increase the activity of the osteoclasts. So which are the cells on your bones that actually break down bone to release calcium into your bloodstream. They can actually increase their metabolism, and it can lead to decreased bone density over many, many, many years. So again, this is important to take into consideration because you want to be able to supplement patients with vitamin D and calcium, and also be able to get regular bone density scans in this population. So again, very important. And finally, in women, so what are things to consider? Things like contraception, childbirth, breastfeeding. So metabolism changes rapidly during pregnancy. This is well understood by most physicians, but it's important, especially in women with epilepsy who are pregnant or planning to become pregnant, that they have very close follow-up with the neurologist. I like to do this typically on a monthly basis during the early phases of the pregnancy, usually within the first and second trimester, just to make sure that they're doing okay, they're not having side effects. I also like to get medication level, so blood tests, like usually every month, to make sure that their medication levels are stable, because I want to make sure the metabolism isn't affecting their levels, and want to be able to adjust the dose at each visit to an appropriate level to make sure that they're not having side effects, but also have enough coverage to prevent seizures. The last thing you want is a pregnant patient to have a seizure during pregnancy, which is not only dangerous to the mother, but also to the developing baby as well. Also, certain anti-seizure medications, they can actually lower the effectiveness of contraceptives, particularly the hormonal contraceptives, because they increase metabolism of these contraceptive medications. So the medications won't last as long, or they won't have as enough coverage, or they won't be as effective as they would be otherwise if you weren't taking these medications. So this is an important thing to note as well, which is why in patients with epilepsy, especially if they're not well controlled or they're on a lot of medications, hormonal contraceptives is typically not preferred, and things like IUDs would be better tolerated and better preferred in this patient population. And certain anti-seizure medications, they're actually toxic in and of themselves to the fetus. They can actually increase risk for certain malformations, and there are certain medications that have been well studied up to this date that are known to cause these. So we want to be able to avoid these in pregnant patients, or if patients are on medications that are known to cause teratogenicity, we want to be able to safely and effectively taper them off and start them on a much safer medication. And again, this requires a dialogue between the patient and the neurologist, ideally months in advance of a planned pregnancy, so that we could safely get them off their previous medication and get them on a new, safer medication that's going to be much safer during pregnancy. And we want to be able to show that they're not only being able to tolerate the new medication, but also have their seizures well controlled prior to having a planned pregnancy. So again, this is very important. It can be tricky because oftentimes pregnancies can also be unplanned, and that just that just makes things a whole lot trickier. And again, it's always preferred and always ideal if a dialogue can be had with a neurologist months in advance of any planned pregnancy, so that we can make this transition safely for both the mother, the patient, and the developing fetus. Okay, so I think that was essentially what I wanted to touch upon and talk about today, just so everyone could get sort of an appreciation for what we as epileptologists and as neurologists think about when we get referred patients with epilepsy, or what most neurologists will think about when talking to patients with epilepsy, getting their histories, thinking about treatments. Again, it's a patient by patient shared decision-making process. So here on this slide, I just wanted to give everyone some resources that are incredibly useful and have information not only for treatment for epilepsy, but also local resources, support groups, et cetera. And I think this is very important for people to have access to. So just putting it out there. So that's about it. That's what I wanted to talk about today. So I guess we have some time for questions now.
Yeah, so I just have a couple of questions.
Yeah.
So it sounds like really communication with your medical provider is key, like having open dialogue about what your symptoms are or changes in medication and etc. So how accessible are our providers and such as yourself at the medical center and at the clinics?
Yeah, so we're typically pretty accessible. So once we establish care with the patient, if they have any questions about the medications that they're on or what the next steps are, we typically get back to them. We have our nursing staff reach out to them. It's a very important, shared decision-making process that needs to get involved, or a lot of back and forth. Sometimes we'll just call the patients ourselves to have that discussion, especially if we feel that their seizures aren't being well controlled and that something more urgent needs to happen. Like for example, I have a few patients whose seizures aren't that well controlled, or they have pretty complicated social situations which make care a little bit more tricky. So I like to talk to them personally sometimes, or have much closer follow-up with them. And oftentimes, like, follow up with epilepsy patients, as long as I get to know them after a visit or two, a lot of it can be done over telehealth, which makes it a lot easier for a lot of people, especially if they have to drive, especially if they're not able to drive, for one, and two, if just being able to drive like a really far, like a large distance, it's not going to be realistic for them. So I like to have that option available for them too. And especially if their seizures aren't well controlled, I like to see them a lot sooner than I would otherwise. So usually like in a couple of weeks, I like to follow up with them, make medication adjustments, ask how they're doing, and take it from there.
Great. Thank you. And then I was curious, how can people best, I know it's case by case, but are there lifestyle changes that people can make or things that can help them with their, while they're going through, medication and treatment and management?
Yeah, so that's a great question. So it's also something I didn't touch upon today, but also very important. Lifestyle modifications. So in general, there are a couple of things that patients can do and should do to make sure that they not only have the seizures well controlled, but reduce their likelihood of having further events. Even if they're on medications, this is very important. So one of them would be making sure you get adequate sleep. So a lot of the time, if you don't get adequate sleep, or you're stressed at work, you're sleep deprived for whatever reason, that can actually lower your seizure threshold. So it can actually make you more likely to have seizures, even if you're on medication. So that's one thing, making sure you get enough sleep. The other thing is also making sure, if you have conditions or any mental health condition like depression, like anxiety. A lot of patients with epilepsy have these conditions, and a lot of patients with epilepsy have comorbid or at the same time they also have mental health illnesses that need to be treated, and being able to treat them together with the epilepsy is super important because one can affect the other. Can also cause an increased risk for seizures. So that's also very important to make sure that if you have depression, if you have anxiety, if you have any underlying mental health condition, that you make sure you mention that to your providers and you try to get that treated, if that's indicated, if your psychiatrist or your therapist or whoever you're seeing for that thinks that that's the case. And oftentimes we like to have a dialogue between the mental health providers, like a psychiatrist and the neurologist. We often work hand in hand in treating patients with epilepsy. The other thing is making sure that you don't skip meals, that you're eating on time, that you're not giving your body any reason to have a seizure, or just reduce the risk, the likelihood of having seizures. Just making sure you have a healthy amount of sleep, you're eating enough food, you're not skipping meals, that you're not overly stressed, that you're dealing with that. Also, making sure that you get, if you're sick, that you get that if you get things like the flu, if you get things like COVID, any kind of fever, any kind of infection can also lower your seizure threshold and increase risk for seizures. So it's important to make sure that, if you're sick, you take it slow, you take it easy, you drink plenty of fluids, you take like things like Tylenol to get your fever down. Just basic things. Just don't brush it off, because you're going to be at a higher risk for having breakthrough seizure events than someone without epilepsy if you have like a viral infection or things like the flu or pneumonia, things like that.
Right. Especially this cold and flu season.
Yeah.
It's been pretty challenging. So, well, that's those were the questions that I had, and I just really want to thank you, Dr. Reddy, for being with us today. This event is being recorded and will be on our website. You can find it at go.d/h.org/HLS. I believe that's what it is. And we, so that this whole presentation will be there for you, and will also be on our YouTube channel. So thank you so much for being with us today. And I hope you have a great rest of the day.
Yeah, thank you for having me. All right, take care.